Okay, so in this video we're going to explore the relationship between scapular dynamic function and the elbow joint and potential consequences which can arise from poor scapular dynamic function and elbow joint related symptomatology, such as biceps tendinopathy, medial epicondylopathy, or pain with the antecubital fossa of the elbow. A common cueing technique that coaches, physical therapists or trainers tend to use when coaching or providing good motor control patterns during the pull-up or chin-up is the concept or idea of scapular resetting or drawing the scapula downwards and inwards prior to the initiation of the pull-up. Now, when segments about its joint's axis are in varying different positions relatively to the other segments about its joint's axis or above or below, this can change whether a stability or mobility requirement is necessary to achieve a task. We know that in 180 degrees abduction of the shoulder joint, due to passive tension on the periscapular muscles, that being teres major, which allows the shoulder blade to ride upwards and out, to reset the scapula into a position midline to the body is actually mobility, not a stability requirement. So I'm just going to get Jessica to explain this for me. Well, I'm going to be explaining it, but to demonstrate the idea, we know that prior to initiation of pull-up or chin-up, we're in a 180 degrees abducted position of the shoulder relative to the trunk. We know that if we were to ask her to draw in the scapula downwards and hold it there, this is actually mobility, not a stability requirement. We have the teres major, which comes in onto this angle, but attaches to the inferior lateral border of the shoulder blade, into the medial stroke of the humerus, and also if you draw your scapula downwards and inwards for me, and we know that this is putting passive tension or stretch on this muscle. So therefore it's a mobility, not a stability requirement. Whereas in this position, if I was to draw the shoulder blade downwards and inwards, it's more of a stability requirement because there's optimal length-tension relationships around the periscapular musculature. But in this position, it's a mobility requirement to draw the scapula downwards and inwards. Having said that, it's very important to train dissociation movement patterns. So in other words, for the shoulder blade to go downward and inwards when the shoulder abducts, or for the shoulder blade to move upwards and outwards when the shoulder abducts. So by moving the segments about its joint's axis, being the shoulder and scapula, moving within and out of phase is very important because it allows the central nervous system to functionally arrange new optimal length-tension relationships. So when an athlete or client can explore its full atherokinematic range independently of other segments, the better the brain can use more of that range to incorporate optimal length-tension relationships to provide better efficiency, force, and for improvement of joint health. So for example, if your client or athlete can only explore within this range, they can only downwardly rotate or stabilize or articulate the shoulder blade into this position here, we know that she's not taking into account a full atherokinematic range. So she knows that, or we know that as examiners, she can't explore that full range, but according to Jessica, that's the only range that she knows is normal. That means her perception will take this into consideration and figure that to be normal, when in fact, if she could explore that full range within scapular function, the shoulders in this position, the brain will have a better idea of where, or a greater stable base of where to optimize length-tension relationships. So this is a concept in my definition of what stability is, rather than looking at stability as a static measure of how well a segment can hold in this position while other segments are moving. When in reality, the perceived notion of what stability is actually a snapshot in time. Same thing with pronation, supination. Pronation or excessive pronators, it's actually a snapshot in time of the full dynamic movement. So having said that, now that we know it's a mobility requirement, not a stability requirement, we're going to test the passive integrity of the teres major. One way to test its length is to push downwards and inwards on the shoulder blade, like your arm, by applying a downwards and inwards movement of the shoulder blade, and then applying passive overpressure to the shoulder. If I find or I can feel aberrant tension in the teres major, preventing the shoulder going to its full 180 degrees abduction, then I know there's some type of increase in neural drive to teres major or reduction in tissue extensibility. if I can get, in Jessica's case, she's pretty good, but if I find that here it's really stuck and I can't get it all the way, then I know it's either teres major or latissimus dorsi restriction. One way to differentiate that is for Jessica to go into lordosis and flexion, so I want to get a low back flexion extension. And if I find during flexion that, if I go back to flexion, if I find that in flexion that the shoulder pushes down on my arm, on my hand significantly, I can associate with the latissimus dorsi dysfunction due to the fact that it's tensioned over low back origin where it inserts into the thoracolumbar fascia. I know that's a latissimus dorsi dysfunction. Where there's no change in the amount of pressure pulling back into my arm when she flexes low back, then it's more of a teres major dysfunction. Taking that further, how can we know that teres major can influence the elbow joint biomechanics? One way we can do that is we can contract the antagonist of teres major, being medial trapezius and rhomboids, and then we can determine what that effect it has on the elbow joint, and then compare that with contracting the teres major and see that, what influence that has on the elbow joint. So we go into that position of a pull-up or chin-up, so 180 abduction, and right now I'm just going to get you to push your left shoulder blade down towards your right glute, and as you're doing that, maintain that pressure there and pull down like you're performing a pull-up. Perfect, perfect. Now, the elbow joint's at 90 degrees flexion. This is a good thing because it's at this angle where the elbow joint moments or force can actually provide a great amount of force to protect the elbow and improve efficiency in force output. But we know that if I was to push down her shoulder blade downwards and inward to get her to reactively contract teres major, so what I'm going to do is I'm going to push your shoulder blade downwards and inwards. I want you to press your shoulder blade up into my thumb and maintain that pressure and then pull up. Maintain this pressure and pull up with the shoulder blade. Pull, 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 maintain the pressure of the shoulder blade, all the way, all the way. And we know, stop. We know that in the same position before, the elbow joint is actually flexed a significant degree more, a significant amount more. And this isn't a good thing. By incorporating or increasing toning the teres major, that's going to change the primary driver from a scapular-driven primary driver to an elbow-driven primary driver. This is a bad thing for the elbow joint for two reasons. If she doesn't have the necessary mobility to draw her shoulder blade downwards and inwards prior to pulling up, this is going to increase the moment arm or distance from the center of mass to the elbow, significantly increasing forces at the elbow joint. Secondly, because she hasn't initiated acceleration upwards due to pulling up, and if it's a primary driven from the elbow joint flexors or muscles or forces acting the elbow will be significantly increased due to the fact that she's starting off in a static position, whereas if she had that full articular mobility in the shoulder blade, then once the elbow joint kicks in, it doesn't have to produce much force due to the fact that she's already gained momentum. So one of the reasons why it's very important to address hypertonicity of the teres major prior to, or if there's related symptoms in the elbow during the pull-up, or if it's a concentric eccentric phase, very important to address the teres major muscle. So, having said that, if you've experienced AC joint sprain in the past, it's probably a bad idea to get into pull-ups or chin-ups along the road. The reason being is because what most clinicians do, or therapists or trainers, is that if they go to observe scapular dynamic function, and we see that the scapula is moving well on the thoracic cage, it's articulating well with the thoracic cage, but one of the problem is they don't realize that the clavicle has quite a biomechanical intrinsic relationship with the shoulder blade. We know that the clavicle posteriorly rotates and elevates quite early on during normal scapular dynamic movement. So one of the ways to test the integrity of the coracoclavicular and acromioclavicular ligaments isn't just by palpating the AC joint and coracoclavicular ligaments, because they have overlying tissues such as the deltoid, upper flap of the trapezius, subclavius, pec minor. It's going to obscure our palpating findings as to determine not only where the tissue and lesion is, but how accurately we can define using our hands where the dysfunction is or has the ligament healed efficiently. But we know a better way of determining the dynamic function of those ligaments is to, I'm going to get you slide down for me. So a better way of determining the function of the ligaments is getting a hand, placing on the clavicle, other hand around the shoulder blade. And I'm going to get you to abduct your shoulder above And if I find that the clavicle is elevating, posterior rotating earlier on, this is a good sign. This means that normal integrity of the coracoid or clavicle and coronary clavicles haven't been breached because they act as passive tensioners on the shoulder blade onto the clavicle. As I said, if we don't feel for clavicle movement, we're going to assume that everything's fine, but it's not. So if we feel for the clavicle, and just say for the patient fully 180-degree abducted shoulder, and we find, although there's good scapular articular mobility on the thoracic cage, but we don't feel for any rotation, posterior rotation or elevation of the clavicle, then we know there's some breach of those ligaments. And this can be potentially hazardous for the shoulder because it can increase the risk of shoulder dislocation, subluxation in this position, in this particular isometric joint range position, because in this position, the latissimus dorsi acts to centrate the shoulder, increasing its congruency. But we don't realize that if the clavicle on that side, due to a breach or rupture of those coracoclavicular ligaments or AC ligaments, if the clavicle can't posterior rotate and elevate, it can't set up the pec major in its line of joint to centrate the shoulder anteriorly, primarily relying on the latissimus dorsi to centrate the shoulder, increasing the risk of shoulder dislocation, subluxation. In particular, if a patient has a history of multi-directional shoulder instability. So that's why it's very important to address the clavicle relative to the shoulder blade when looking at the shoulder as well.